the objectives. We're going to talk about the degree to which behavioral health patients present, the major risks that they present with, and then discuss strategies. And there's going to be a lot of information on slides, and some of them I'm going to go through fairly quickly, but I wanted you to have a lot of content in the slides that you could have for future use. So why are we talking today? I think, the fact that I think there are over 400 registrants for this webinar, I think that speaks for itself. We're talking today because this population is a challenge in acute care and is a population that many organizations struggle with in terms of providing safe care. So we do have to look at the number of Americans with behavioral health disorders. And right now, I've had people answer this question and say, it's 70%. I happen to agree with that at some level, but the data tells us that about 26% of Americans right now are walking around with a behavioral health disorder. So that's 1 in 4 people. And they may or may not be treated, but 1 in 4 people have a behavioral health disorder. And then we have to look at the number of Americans that will suffer, so that while 26% are suffering now, what the World Health Organization has told us is that 50% of the world will suffer a significant mental health issue. And when I speak about behavioral health and mental health, I'm also referring to chemical dependency, because that is a DSM diagnosis and it is a mental health issue. So just because you might be 60 years old now and you don't have any significant behavioral health issues doesn't mean that you may not have it in the future. And then the leading cause of healthy life lost, and the World Health Organization has also told us that the leading cause of healthy life lost in the world is mental health disorders. So, I think that we've spent many years dismantling the mental health system and kind of ignoring the fact that behavioral health is a significant issue in many, many people's lives, and those are people that we care about. And then who has behavioral health disorders? That would be, your husband, your mother, your father, your sister, your brother. We all know many people and have had many people in our lives that have been challenged and suffered with behavioral health disorders. So they are people that we love, that loved us or love us, and we do have a responsibility, especially as healthcare providers, to assure that they're both safe, that we provide quality services to them. So the World Health Organization has also given us other data that I'm just going to speak to real quickly. Out of the 10 leading causes of disability for mental health disorders, and more significantly, by the year 2020, major depressive illness will be the leading cause of disability in the world for women and children. And this is very, very significant. I happen to think that we're there now, but the World Health Organization is holding to 2020. And then I've had people ask me, what about men? And I jokingly say, well, men cause the depression. No, and don't take offense, men, but it's just a joke. But for men, it's second leading cause of disability. So men are not immune to this. It just happens to be that women and children will suffer more. So ECRI, and many of you are familiar with ECRI. They do wonderful work, and they have a PSO, and they have gathered many, many thousands points of data from their PSO. And in 2014, they came up with a top list of patient safety concerns. And on that list in 2014, number 5 was a failure to adequately manage behavioral health patients in the acute care setting. So this is why we're talking today. Staff are reporting significant events that are related to managing behavioral health patients in their treatment settings. And then in 2015, the list included number 3, managing patient violence, which is very, very significant right now in organizations, and opioid-related events. So there's research on this, there's literature on this, there's data on this, and we have to look at this as an opportunity right now to do better and to be safer. Comorbidity really is the norm. Sometimes we don't know which came first, the chicken or the egg. Did somebody develop a substance abuse disorder or a behavioral health disorder because of a physical condition, or did they develop the physical condition as a result of the mental health status? So we know that 68% of adults with a behavioral health disorder have at least one, and typically 2 to 3, medical disorders. Lots of comorbidity. And then we know 29% of those with a medical disorder have a behavioral disorder. And I do, my main job is really conducting risk assessments for settings around the country. And when I do this, I ask organizations to provide me information on their discharge data and look at primary and secondary diagnoses of their overall acute care population. And inevitably, that's anywhere from 29 to upwards of 43. So if you really want an idea of what you're seeing in your organization, look at your discharge diagnoses over the course of a year and figure out what your rate is, because chances are at least 1 in 3 of your patients has a behavioral health condition that could be contributing to their inability to manage their medical condition. So it really is mind over matter. We know that once we control our mind, we can conquer things physically, and this is scientifically proven. So mind controls behavior, behaviors determine lifestyle, and lifestyle is a major contributor to physical health status. So there is no way that we can work to achieve population health if we do not assist people in managing their mind and their mental health, period. So, we're really talking today about the liabilities and exposures that are related with this population, which, are very, I'm a risk person and a patient safety person, so this is what I focus on in terms of organizational liabilities, professional liabilities, and exposure. So this is kind of a list that really organizations that have had an adverse event have suffered. So we're looking at media attention, which can be quite intense, regulatory risk, of course, with CMS, facility licensure action, healthcare professional liability risk, and then, of course, there's frequent legal claims that, those risk managers are on the line are familiar with. And I have to say that, behavioral health events are low volume, but they're very high profile. So, and they can be very catastrophic for reputation of the organization as well as regulatory reasons. So I also work as a legal nurse expert with attorneys around the country on bad outcomes with behavioral health patients, patients that elope from an ED and harm somebody else or harm themselves, patients that commit suicide inside of an acute care setting, on and on and on. So the frequent legal claims generally are in line with the Joint Commission's findings of root causes for sentinel events. And that is inadequate risk assessments, lack of a safe treatment environment, and we'll be talking about all these things, lack of appropriate monitoring, and untrained staff. So these are, if we're going to look at anything, these are the areas that we need to look at in terms of how are we safely managing the patients that have a behavioral health comorbidity or primary diagnosis throughout our acute care setting. That includes ED. And untimely transfers to appropriate settings. And that's particularly true in the ED or patients that are admitted to a unit because there's no psych bed that wind up being in an inappropriate treatment setting for extended periods of time, which increases risk and makes the patient less safe, as well as staff less safe. So the prevalence, real quick. Emergency departments, we know the emergency department has turned into the primary care provider for behavioral health patients because essentially they have nowhere to go because we have dismantled the mental health system in this country. I hope, I have a magic wand to create those resources. So my goal is to assist organizations in managing these patients safely wherever they present. So the emergency department is estimated anywhere from 30 to 40% of the patients that enter into the ED are either primary or secondary, have psychiatric diagnoses or substance abuse issues. Some data says it's about 1 in 8 So, the data is very hard to recognize, but when I do risk assessments of EDs and talk to the staff, typically they'll have 6, 7 patients a day, if not more. And some of you are probably laughing at that because you have 15, but 6 or 7 a day can be quite overwhelming at times. So the inpatient units, we talked a little bit about that already. We're looking at close to 30-40% of inpatients have a secondary or primary psychiatric diagnosis, which means that, we really can't expect that just because the patient isn't there for a behavioral health condition means that they're not going to exhibit behavioral health symptoms. And so that's why when we talk about competencies and having adequate resources, it really needs to be across the board for staff so they can manage any patient that begins to demonstrate, and not to mention visitors and family members. So then we look at primary care. We know about 80% of persons with behavioral health conditions are getting their care from a primary care provider, again, because of lack of resources. Is that safe? Well, it's got to be safe because that's all we have. So it's really up to primary care providers to get up to speed with how to safely manage the population. And then we look at long-term care, and more, of course, I get concerned about that because I'm headed in that direction, as are we all. And there's an appalling rate of mental illness and behavioral issues with long-term care patients. And some studies say patients in assisted living and as well as nursing homes, the rate can be as high as 50%. And what I have seen over the years is that there's an appalling lack of treatment. Mental illness at any age is not normal. So the fact that somebody is 85 and having anxiety symptoms or irritability or other symptoms that are making them behaviorally act out should not be considered normal and can benefit from treatment. So let's not forget employees. And many of us are leaders or have departments where we're managing our employees that are also suffering behavioral health conditions. And again, at least 26% of them, and we know who they are, by the way, but a third of those with behavioral health illnesses are employed. A fourth of the workforce has a behavioral health or CD disorder, which is in keeping with the 25-26%. The most common being alcohol abuse, dependency, major depression, and social anxiety. And so these are the most common disorders that employers manage on a routine basis. And then 71% of workers with behavioral health disorders have never sought help. And that's due to a lot of reasons, stigma, lack of availability, lack of identification of the need for help, et cetera, et cetera. So I think I've given you a pretty good idea of what the pink elephant in the room is, and that is behavioral health, and that we need to look at all of our patients that come into the continuums of care as potentially having a significant disorder that could create risk, either for them or for the organization. And then the leadership concerns. The ED is a primary care setting, I've said, the suicides in healthcare, which are greatly underaccounted for because the vast majority of organizations that I do risk assessments for that have had a suicide event do not report that to the Joint Commission. And right now the Joint Commission is the only one that's putting out data related to this. So we need to look at that data and probably quadruple it because CMS is really the only one that has captured all that data and for whatever reason refused to put that out to the public. There is increasing healthcare aggression, of course, that OSHA, Joint Commission, CMS have all been concerned about in the last several years and have required organizations to implement workplace violence programs that we will talk a little bit more about. The readmission rates, a lot of data on readmissions, upwards of 70+% of readmissions have significant behavioral health diagnoses, according to a study that was done by the American Hospital Association, which I put in the reference for you. So if we're looking to improve quality outcomes and performance measures, then we have to look at how are we managing this domain of a person's life. The longer length of stays, they're double with behavioral health patients. We have increasing healthcare costs, of course, and it goes on and on and on. And our liabilities, of course, then come into play when we don't provide safe and adequate care for patients. So the top behavioral health risks that we're going to talk about are really these: chemical dependency, suicide, aggression, and elopement. And when I talk about the strategies are going to relate to pretty much all these risks. A lot of the strategies that we use are effective for all of these risks. So when we talk about, what strategies do we use for a suicidal patient or an aggression patient or a patient that's at elopement risk, the strategies are very, very similar, and they're high-risk management strategies. So the opioid epidemic I just want to briefly mention because I happen to work as a real nurse a couple times a month in detox and rehab with comorbid substance abuse and psychiatric patients. But I found this data really quite alarming, and this was put out by the head of the the FDA in 2014, where 100 million or 40% of Americans have chronic pain, and to me that was astonishing. There's a fourfold increase in opioid sales, and deaths have more than tripled in 10 years. The U.S. consumes 99% of the world's hydrocodone, which makes you think, what are other countries doing to manage pain? Of course, they're using alternate methods, non-prescription methods to manage pain. They have to be because we're using all the hydrocodone. And then hydrocodone is the most prescribed medicine in the U.S. So that really speaks to the extent to which we can really call this an epidemic. And it is. And it's a sad epidemic where many, many people are dying daily. Suicide, we cannot predict. There is no completely valid and reliable tools to assess suicidality. So don't be under any false illusions that the tools that you're using are going to be completely valid and reliable for your assessments. They are only part of the process. It's the 10th leading cause of death. The military, there's 22 deaths a day by vets, both active and inactive, and 31% of the clinical population, meaning the diagnosed behavioral population, and 24% of the general population, meaning you and I, will consider suicide in their lifetime. That's alarming as well. So I think that a lot of people are quite educated with suicide, but yet we have not yet perfected means in which we can get the rates to decrease because they are going up. Aggression. OSHA has put out lots of information for organizations to begin to address this issue, and the healthcare sector leads all industry with aggression. I mean, any other industry you can think of does not come close to the rate of aggression and violence in healthcare. And to me, this is very, very alarming. ED nurses are the most aggressed upon, and what OSHA, of course, recommends and what I recommend is that we establish this culture of zero tolerance. And that doesn't mean that we're never going to have aggression in our setting, but what it means is when it does happen, we have a plan, and we have an immediate plan, and we work to be proactive and manage aggression at the lowest level. And I'm going to be speaking more about that. So elopement, premature patient prompted discharge. I thought that was funny. I saw it once in some literature, and I thought, well, there we go, PPPD. It now has a name. But, these can be medical, legal disasters, and providers have a duty to ensure safety, even if the patient refuses care. So if we have a patient in the ED or a patient on a unit that is acting unsafe, we have a duty to keep them safe. And, of course, court cases have clearly resounded that alarm. And so everyone, I think, is pretty much on board with that. The numbers of behavioral health patients that elope are really unknown, but we do have this, what we call the LWBS, left without being seen data, and the question is, what portion of that data is actually patients that elope? So I don't think that we're really capturing adequate data, and of course there's no good benchmarks out there for us. We have very few benchmarks for behavioral health, which is really unfortunate. And the major reason for patients eloping is long waits in the ED. They feel ignored. They feel like no one is helping them. They have long waits for transfers. They have long waits for admissions. And if you had to sit hours and hours and hours in an ED where you were already anxious or depressed or agitated, you might think about leaving too.